So my system uses Health Connect or Epic. We like to rename everything so it feels like it's ours within the Kaiser Permanente system. And so there's smart phrases are basically things that you don't have to keep typing over and over again. And this queues up with every telephone visit that I perform. So I literally am asking these same questions every day for 7 days. Do I need to do it for 7 days? Probably not, but as a first starter, I wanted to overdo it. And so we're able to track this. Probably takes 8 minutes, the first telephone visit, and then by day 5, 6, 7, the patients are answering the questions before you even ask them. And like I said, it's free and reliable. So the iFeed score is, like we alluded to before, really a game changer because it really allowed us to track GI recovery rather than just, oh, I feel okay, versus I feel less than okay. You also, by doing these daily 7 days a week phone calls, I learned the iFeed system inside and out, and I learned that it is validated, and I'm validating it in my own practice by using it. So when we looked at the pain scores in the blue bar, the iFeed scores in the blue bar, the pain scores in the orange bar, and then the narcotic use in the white bar, which is oxycodone 5 milligram tablet. I was shocked to see how little my patients were using narcotics, even though their pain scores were reported higher than one would anticipate. And if they were in the hospital, the nurses would not be leaving the room without giving them a narcotic. So patients were tolerating pain scores of 7, 8, 9. Others on post-op day 1 thought their pain score was 2, 3, so an average in the 4s. So this actually led to a change of practice where we initially prescribed 20 of the oxycodone 5 milligram tabs. We now prescribe 10, which is a big game changer for us as well. And again, by calling, I learned that patients were tolerating a higher pain score than I would have otherwise thought, and using less narcotic than I would have otherwise thought. So my preferred surrogate for hospitalization is just use the phone. Dr. Talamini was the chairman at UCSC when I was working there as well, and he used to always say at M&M, one of the greatest surgeon's tools is the phone, both responding to our colleagues, calling our patients back, and in this case, as a surrogate for hospitalization. Thank you very much.
Can we cue Dr. Lee's second video?
Hi, my name is Lawrence Lee, and I'll be arguing that there's an app for that. So the question that we have to resolve is how best to follow patients after the hospital, especially in the context of same-day colectomy. One aspect that's very commonly quoted throughout the medical literature is patients' unhappiness or kind of dissatisfaction with the post-discharge follow-up or the post-discharge experience. And one common theme across many different studies is that patients have concerns about access to healthcare provider information if they have certain concerns or complications once they leave the hospital. Luckily, there are many different commercially available mobile health platforms that are ideal for this type of thing. At the McGill University Health Center, we instituted our own mobile health post-discharge remote monitoring app, which included our patient education booklet, and this was simply the standard enhanced recovery pathway that we put in the PDF form, as well as a daily 5-item questionnaire, which started upon discharge and continue up to day 7. And really, as you can see here, it's kind of equivalent to virtual rounding. Is your pain controlled with oral pain pills? Are you able to drink liquids without nausea? Are you passing gas or bowel movements? Do you have a fever? And is your wound leaking? Anytime there is a kind of negative response to these questions, that it prompts the healthcare provider to contact the patient either through the app, which contains a HIPAA-compliant patient-physician communication features, or another member of the team to have a virtual or telephone follow-up with the patient. When we instituted this mobile health platform, we showed that the number of preventable ED visits, so that these are counted as the percentage, the types of ED visits that could not be avoided. So the ones that had to have some sort of CT scan or readmission for a real medical complication after surgery, these preventable ED visits decreased significantly with an incident rate ratio of 0.34. Although the total number of ED visits didn't really change between the two groups. Although this study showed us that we were able to identify adverse events through app-based interactions, in that none of the patients who went to the ED went so unnecessarily without first being contacted through the app. This app had high patient satisfaction, high usability, and most of the patients felt that the app improved communication. And one very important aspect that I'm sure everybody's thinking about is that the average number of messages per patient in the first 7 days after discharge is about 7. So that's literally about 1 per day, all right? So we're not talking a significant time burden here. In the context of same-day discharge after laparoscopic colectomy, we use the same app with the same functions as I had just presented. And you can see here that about 80% of patients felt that their concerns and symptoms after surgery were adequately taken care of using the mobile phone app. So in summary, mobile health remote follow-up after colorectal surgery is feasible and is not particularly associated with high user burden. It may decrease unnecessary e-visits and is associated with high patient satisfaction. Thank you.